So thank you very much. I'd like to thank the organizers for allowing me to have this opportunity to present to you today. And as we indicated, it's not reacting, sorry. One moment. That seems to work. Plug the mouse in. Okay. All right, so we're going to start my presentation with a case study, perhaps something that some ideology of something that you might have seen in your practice as well. This is a 52-year-old African-American male. He presents with muscle weakness and a potassium of 6. The patient is notable for having CKD Stage 4, hypertension, high blood pressure, type 2 diabetes, and he's also constipated. The medications are noted to be a RAS blocker for his hypertension and insulin for his diabetes. So in managing this patient, what might your first strategies be? Should you discontinue the RAS blocker for his hypertension and find a replacement therapy? Should you initiate dialysis because his renal function is declining? Should you refer the patient to a dietitian or a nutritionist to be counseled on dietary sources of potassium? Or should you continue the RAS blocker, add a diuretic, treat his constipation, and actually encourage the patient to eat a high potassium diet? So I want you to think of these different types of answers and as we continue to go through this presentation. So let's just remind you of the regular potassium homeostasis. If you were to take in a diet of about 100 milliequivalents of potassium, the kidney is responsible for about 90% of its excretion. There is a small component that's also regulated by the gastrointestinal tract. Because this is a relatively sluggish process, we also have intrinsic factors such as insulin and beta-adrenergic stimulation that shifts the potassium inside the cell until it can actually be regulated, potassium homeostasis, through the kidney. Now, the normal kidney has this incredibly large capacity to excrete potassium and maintain a normal serum potassium concentration. And I think this is best illustrated by these 5 different studies. And what these studies were able to demonstrate is that they took individuals with a relatively low potassium intake and actually significantly enhanced the amount of potassium that these individuals were consuming. But quite noteworthy is that you can see that even despite the fact that this is a significant increase in dietary potassium, the relative change in serum potassium is almost negligible. Now, why is this important? Well, as we just heard, that there is an increased mortality rate associated with hyperkalemia. In this retrospective study, what they were able to demonstrate is that when individuals came into the hospital with an incidence of hyperkalemia, there was a graded effect, such as that the higher amount of potassium or the higher amount of hyperkalemia is associated with an increased level of overall mortality. We just saw these U-shaped curves as well, and what's quite noteworthy about these is that, as you can see, that there is an incidence of hypokalemia, which is also associated with mortality, but hyperkalemia is as well. And what this is also demonstrating is that as we increase in our age and or have any comorbid factors, there's a significant enhanced overall level of mortality associated with hyperkalemia. So what, again, are these causes of hyperkalemia? Well, the first is we always have to rule out is pseudohypokalemia. This could be associated with the blood draw and the like. The next is that there's reductions in renal function, which we'll talk a little bit more about in a moment. Pharmacology also has an impact in overall increasing hyperkalemia, especially those RAS blockers, which we give our patients for the cardiorenal protection. And lastly, we often think of dietary consumption. So this is just to remind us that as kidney function declines, there's a significant increase in the rate or the incidence of overall hyperkalemia. So like our case study, CKD Stage 4 is associated with a higher level of incidence of hyperkalemia. This is just sort of a graph depicting what might actually happen in a normal homeostasis with a normal functioning kidney. So what I'm demonstrating here is that typically a person eats about 3 meals a day, and you have a small but within normal range spike in your potassium following the consumption of a meal. And this is in a normal functioning healthy individual with a normal functioning kidney. Now all of a sudden we overlay CKD, and what we find is that there's a higher baseline and the excursions are slightly different compared to what happens in an individual with a normal functioning kidney. Now we overlay a RAS blocker and an individual who also has a declined kidney function, and we again see that there's an elevated level of the baseline, but the excursions are significantly different with respect to the overall processing of potassium. Such that when we look at these different guidelines with respect to RAS blockade, we find that there are organizations that are quite stringent. And that is that as soon as you see an elevation in overall potassium level, these organizations are recommending reduction in overall RAS treatment. But there's also data to suggest that when you actually reduce or have suboptimal RAS treatment, this is actually associated with a doubling of mortality across patient subgroups. So we can look at individuals who actually need these different RAS agents, and what we find is when we have suboptimal or we reduce the amount of RAS blockade, what we end up doing is significantly increasing the overall level of mortality. So what does this do? Well, this puts us in a relative catch-22, and that is what we really want to do is we want to increase the level of RAS in order to provide that cardiorenal protection. Well, at the same time, we want to reduce the overall incidence of hyperkalemia. So how is it that you actually treat these individuals? So just as an interim summary, what we've discussed so far is that hyperkalemia is common amongst our CKD patients. Hyperkalemic events are associated with worse outcomes, such as cardiovascular events, muscle weakness, as well as impaired acidification. Pharmacology used for treating blood pressure actually causes the hyperkalemia, and subjects that require the RAS blockers are suboptimally treated because of the hyperkalemia. So let's go back again. So we've talked a little bit about after you've looked at your patients, such as our case study, we've ruled out that they have a pseudohyperkalemia. We know that they have a reduction in their renal function. We know that they're also on a RAS blocker. So probably reflectively, what all of you might do is actually go in and begin to counsel this individual about their dietary consumption of potassium. Now, potassium actually has been listed as a nutrient of concern, and many of you might think it's listed as a nutrient of concern because we're worried about its association with hyperkalemia. But in actuality, the Food and Nutrition Board of the Institute of Medicine actually established recommendations for potassium consumption to be about 4,700 milligrams per day. But the NHANES estimated that we're consuming about half of what we're actually supposed to be consuming. So the reason that potassium is listed as a nutrient of concern is because we actually don't consume enough potassium. Potassium of our prehistoric ancestors was estimated to be about 15,000 or full-fold higher than actually what we're consuming today. So our prehistoric ancestor and our prehistoric kidneys were designed to be able to take these huge loads of potassium and have regular, normal potassium homeostasis. And so currently what we have is an inadequate consumption of potassium, and this has been implicated in various diseases such as hypertension, cardiovascular disease, osteoporosis, as well as kidney stones. So this is just a cartoon representing some of the many health benefits associated with eating a diet that's high in potassium. It prevents muscle cramps, it boosts the nervous system, again, reduces blood pressure and the like. And so what do we do with our patients? The first thing we do is we actually remove the potassium from their diet when there actually could be multiple medical benefits associated with eating high potassium foods. This is just a chart listing the different types of dietary sources of potassium. And I leave this or question this to you. Is it possible, or do we know, do all of these different dietary sources of potassium, are they metabolized in the same way? We know that insulin facilitates the uptake of potassium into the cell. If you have a food source, such as a banana that has a high carbohydrate intake, perhaps it is having a different effect on intracellular potassium than, say, an avocado, which is relatively low in carbohydrates. So the question is, do we actually know how all of these different foods are contributing to our overall serum potassium? So I'm going to go back and actually remind you of this, and that is that when we actually push potassium in individuals, and again, these are healthy individuals, what we found was that there was actually little to no change in serum potassium. So what happens now if you take a population of hemodialysis patients? And I found this study to be quite remarkable. Reflexively, we all say is as soon as you push potassium in a population of hemodialysis patients, what you would see is as these individuals consume more potassium, they would have higher levels of serum potassium. But indeed, if you look at this graph, there's not hardly any association between plasma potassium and potassium consumption. And this is in a hemodialysis population. Specifically, the regression line describing this relationship indicates that, as reported, dietary potassium intake went from a low of 500 milligrams all the way up to 4,500 milligrams, a 9-fold difference, yet there was a small, almost imperceptible increase in overall serum potassium levels. Here's another study that actually looked at the same sort of effect. These individuals completed 3 24-hour dietary recalls, and again they found that there was no significant correlation between the serum potassium and the absolute reported potassium intake. And this is just to show you what these graphs actually look like. So again, reflectively, what do? We call in that dietitian and we ask her to remove the potassium from this patient's diet. Yet do we have enough evidence to support this? And I think that this is an opportunity for some new and novel research to be able to take place. So one question you might say, well, these individuals were on hemodialysis, and the other individuals that I showed with modest changes in serum potassium, they were healthy, normal individuals. So is there a reason for us to restrict to high potassium plant foods, and is this appropriate in our CKD patients? In actuality, there's even data to support that we should actually increase the amount of potassium that is consumed in our CKD patients. In this study, it showed that as the potassium increases, there was a reduction in all-cause mortality in CKD patients. So dietary potassium intake in patients in declining renal function, the diet, if any of you have ever tried to follow the diet that we give to these renal patients, it's incredibly difficult to follow. There are numerous health benefits that are associated with consumptions of fruits and vegetables. Is it possible then that we should actually liberalize the diet to improve the overall enhancement of well-being as we actually allow these individuals to eat and enjoy some of the benefits of fruits and vegetable diets? Now, how might this be? What might be happening? Is it possible that during the time when actually your kidney function is declining, is it possible that the gastrointestinal tract is taking up a bigger burden with respect to overall potassium homeostasis? And is there precedence for this? Again, the role of the gastrointestinal tract, the potassium from the diet in the gastrointestinal tract is absorbed in the small intestine and secreted in the colon and rectum in exchange for sodium. Small amounts of potassium is excreted actually in the feces. Chronic diarrhea actually increases fecal potassium excretion, and chronic constipation, which we often find in our patients, is associated with hyperkalemia. And yet we've been utilizing the gastrointestinal tract for quite some time. If you think about the drugs that we currently employ to reduce hyperkalemia, it's K-oxalate paired with sorbitol, which actually facilitates diarrhea or enhanced stool volume, which actually causes a reduction in overall serum potassium. So there's also in the next presentation, you're going to hear there's new and novel binders that also work within the gastrointestinal tract to reduce overall serum potassium. So is it possible that in individuals that have declined renal function that we actually can now start to push a little bit harder on the gastrointestinal tract as an avenue for overall potassium homeostasis? So in conclusion, hyperkalemia is a serious medical condition that can lead to life-threatening cardioarrhythmias and sudden cardiac death. Hyperkalemia is most often seen in patients with impaired renal function and cardiovascular comorbidities. RAS blockers, which enhance the incidence of hyperkalemia. The normal kidney has this incredibly large capacity for excretion of dietary potassium. There are actual health benefits associated with eating diets that are high in potassium. And there are new and novel drugs, as well as the old drug, the SPS, the K-oxalate, that actually rely on that gastrointestinal tract to facilitate potassium homeostasis. I think that this is a time then where we should maybe call for interventional trials to be that are probably necessary to determine whether increasing dietary potassium is actually beneficial for our CKD patients. So I'm going to end then with a case study. This is, again, I'll remind you, this is our African-American individual who comes in with muscle weakness and a potassium of 6. He's notable for CKD Stage 4 with hypertension, and he's also on a RAS blocker. So again, I ask you, what should you do with this individual? Do you discontinue that RAS blocker for his hypertension and put him on different therapy? And remember that we saw that discontinuing or augmenting the RAS blocker is associated with enhanced mortality. Do we initiate dialysis since his renal function is declining? Do we refer this patient to the dietitian and have him counseled about possible sources of dietary potassium that he should be excluding from his diet? Or maybe a paradigm shift or food for thought. Perhaps we continue the RAS blocker, add a diuretic, and treat the constipation and actually encourage the patient to perhaps eat a high potassium diet. Thank you.